I want you to picture something for a second. Imagine, like, a sperm whale plunging thousands of meters into the freezing abyss of the ocean.
Oh, wow. Yeah, the water pressure at those depths is just absolute crushing force.
Right. I mean, we're talking about environmental pressure that would instantly crumple most human-engineered structures, like
Yeah.
like an empty soda can.
Exactly. It's immense.
Yet the natural seals on that whale, its mouth, its blowhole, or its anal sphincter, they somehow withstand those sudden, massive shifts in pressure without instantly taking on freezing water.
We look at that and, we see a phenomenal feat of marine biology and physics. But we tend to compartmentalize those examples as extreme alien scenarios happening miles below the ocean's surface.
Right, like it has nothing to do with us.
Exactly. But what is truly fascinating about the literature we are looking at today is that you have a surprisingly similar engineering marvel operating inside your own body every single day, governing forces that are, relatively speaking, just as violent.
Well, welcome to this deep dive. Our mission today is to unpack a whole stack of medical, biomechanical, and physiological sources to answer one highly specific, but honestly mind-blowing question.
And it really is mind-blowing.
It is. How exactly does the inner lining of the human urethra prevent urine leakage when the body experiences sudden, intense abdominal pressure?
Yeah, we are talking about the sheer physical force of a heavy cough, a violent sneeze, or lifting something heavy at the gym.
Right, because I think the standard assumption most people have about urinary control is, well, it's heavily biased toward muscles.
Oh, totally. When we think of preventing a leak, we usually just think of voluntarily squeezing the pelvic floor,
Oh, right.
like performing Kegel exercises.
Yeah.
It's a very mechanical, lever and pulley way of looking at human anatomy. The muscle contracts, the tube closes, and continence is maintained.
But the sources we're analyzing today reveal a system that is infinitely more complex than just a simple muscular clamp.
Vastly more complex.
We're looking at a highly sophisticated, fluid-based, and hormone-driven mechanism. There is a hidden structural hero in this story called urethral mucosal coaptation.
That's the key right there.
And honestly, by the time we finish sorting through the physics and the clinical data here, you are going to completely rethink the biological plumbing that keeps you dry.
Yeah, to really grasp the mechanics of this, we kind of need to abandon the traditional textbook illustration of the female urethra.
The one that just shows a basic hollow tube.
Exactly. It's frequently depicted as this simple hollow tube, roughly 3.5 to 4.5 centimeters in length. But calling it a simple tube completely misrepresents its actual function.
So what is it then?
It is way better understood as a highly sophisticated, multi-layered valve.
Okay, so looking at the anatomical dimensions in the literature, the inner diameter is about 5 millimeters, or a 15 French. But the conical detail, and this is what stood out to me, is that under normal resting conditions, it maintains a 0 lumen.
Right.
Meaning it is completely closed, there is no empty space in there whatsoever.
The mechanism achieving that 0 lumen is really where the biomechanical magic happens. The inner layer, the epithelium, is deeply enfolded, and it sits right on top of a highly elaborate submucosal vascular plexus.
A vascular plexus.
Yeah, this dense dynamic network of veins and arteriovenous anastomoses.
Which basically means direct shunts between the arteries and veins, right?
Exactly. And they fill with blood to create this thick, spongy core right inside the urethral wall.
Reading through the descriptions of this vascular plexus, I just kept coming back to a plumbing analogy, or honestly even basic home insulation.
Oh, the weather stripping idea.
Yeah, like if you have a leaky pipe fixture, you don't just torque the metal pipes together as hard as you can. Metal squeezing against metal will still leave microscopic gaps for water to escape. You install a rubber washer.
Right.
Or if you have a heavy wooden door keeping out the winter cold, slamming the rigid wood against the rigid frame doesn't stop the draft. You line the frame with plush weather stripping.
That's a great way to visualize it.
Because that pliable, cushiony filler molds into every single crevice to totally block the flow.
And that concept translates perfectly to the medical term mucosal coaptation, where these soft, blood-filled mucosal surfaces come together to form a watertight, hermetic seal.
Wow.
Because without that spongy vascular filler on the inside, the outer sphincter muscles would just be squeezing against a rigid structure.
And a rigid tube under external muscular compression is inevitably going to have gaps and folds, right?
Exactly, and fluid will always find those gaps. The inner cushion is just a non-negotiable requirement to completely block the flow.
So if that vascular sponge is the weather stripping forming the hermetic seal, then a sudden sneeze is basically the equivalent of a hurricane hitting the door.
Yeah, That's a good way to put it.
Because a sneeze creates a massive spike in intra-abdominal pressure. The diaphragm thrusts downward, the abdominal wall contracts, and the bladder is caught right in the middle of that pressure cooker.
It is the ultimate stress test for this anatomical valve. The pressure inside the abdominal cavity skyrockets in like a fraction of a second.
But logically, if the abdomen squeezes the bladder like a water balloon, the sheer hydraulic force of the urine pushing downward should pry that structural pipe wide open.
You would think so.
But it doesn't, which brings us back to the rail analogy from the research.
Yeah, the physical laws governing the diving whale and the female urethra are remarkably similar, which is wild. When a whale dives, the external water pressure is immense, but it doesn't force water into the whale's orifices because the anatomy basically functions as an inward opening door.
Right.
The external pressure itself forces the seals tighter together.
Wait, so let me think through the mechanics of that in the human body. If the pressure from the sneeze is pushing the urine down into the upper opening of the urethra,
Then the only way the tube doesn't blow open is if that exact same sneeze pressure is also pushing on the outside of the tube, squeezing it shut.
so the structural integrity of the seal relies on equalizing the pressure.
You have just described Pascal's law of hydrostatics.
Oh, nice.
Yeah, the principle states that any change in pressure applied to a completely enclosed fluid is transmitted undiminished to all parts of the fluid and the enclosing walls.
Okay, so how does that play out anatomically?
The key anatomical factor here is that both the bladder and the proximal urethra, the upper portion, are located inside the abdominal cavity. They are suspended inside the same fluid-filled water bag of the abdomen.
So when the diaphragm drops and abdominal pressure spikes, that force doesn't just act on the bladder.
Right, it acts on everything within that cavity equally. There is a 100% transmission of pressure.
Wow.
The exact same force pushing the urine down from the bladder is simultaneously wrapping around the outside of the proximal urethra, actively compressing the walls together.
So the sudden pressure actually reinforces the closure.
It does. In fact, the physical models and the sources indicate that the bladder itself would rupture before the internal opening of the urethra could be pushed open by internal hydrostatic pressure alone.
That drastically changes how we view the whole system. The sneeze isn't fighting the seal, the sneeze is actively clamping the seal shut.
Exactly.
But for that clamping action to actually stop fluid, we have to look at the flow resistance. And the sources bring up the Hagen-Poiseuille law to explain the mathematics of this.
Right. The Hagen-Poiseuille law is fundamental to fluid dynamics.
Yeah.
It dictates the resistance of fluid flowing through a cylindrical tube. And the most critical variable in that equation is the radius of the tube.
Because resistance is inversely proportional to the radius to the fourth power.
Yes.
That exponent is the key. To put that into perspective for you listening, if you shrink the radius of a tube by half, the resistance to the fluid doesn't just double, it increases by a factor of 16.
And because the mucosal coaptation, that blood-filled vascular sponge, has already reduced the radius of the lumen to absolute zero, the mathematical resistance to flow becomes infinite.
Meaning urine simply cannot pass unless the structural walls of the tube are actively pulled apart.
Correct. But applying Pascal's law to a flexible tube presents a mechanical problem.
How so?
Well, if you apply equal external pressure to a tube suspended in midair, it might just shift or displace.
Yeah.
To actually flatten a flexible tube, you need to crush it against something solid. There has to be an anvil.
Oh, right. And the anvil in this anatomical system is a structure known as the hammock.
Yes, the hammock.
For the equal pressure transmission to effectively crush the urethra closed, it requires a firm backstop. This is provided by the anterior vaginal wall and a supportive layer of connective tissue called the endopelvic fascia.
Right, which forms a literal hammock underneath the bladder neck and the urethra.
So when the abdominal pressure spikes, the urethra is compressed violently against this firm connective tissue, which instantly reinforces the mucosal seal and prevents it from just getting displaced.
The coordination required here is stunning. You've got the vascular sponge providing the zero lumen seal, the abdominal pressure providing the dynamic clamping force, and the hammock providing the structural backstop.
It's brilliant. But knowing all these components exist still leaves a major question.
Which is how much of the actual closure pressure comes from this passive vascular sponge versus the striated muscles we can actively control.
Right. And to isolate those variables, the sources detail an incredibly specific and honestly quite intense clinical study known as the Rudd experiment.
Oh, this study is a fascinating piece of physiological research.
If you are listening and wondering how researchers isolate these specific internal forces, the Rudd experiment is a perfect example of extreme scientific dedication. They took 5 women who were already scheduled for pelvic surgery and measured their urethral closure pressure at 3 distinct stages.
Right, first they took a baseline measurement just before anesthesia.
But the second stage is where it gets crazy.
Yeah, they administered a neuromuscular blockade curization, which is a paralytic agent that completely shuts down all striated muscle activity.
This effectively takes the voluntary pelvic floor muscles completely offline, allowing researchers to measure the closure pressure when the muscles are doing absolutely nothing. I mean, paralyzing conscious or semi-conscious patients just to measure urethral pressure sounds extreme, but it was really the only way to eliminate the muscular variable.
It was. And then they took it a step further for the third measurement.
What did they do?
While the muscles were paralyzed, they temporarily clamped the blood vessels supplying the urethra. They physically cut off the blood flow, graining the submucosal vascular plexus.
They literally deflated the weather stripping.
Exactly. And the breakdown of the data from those 3 stages completely recontextualizes continence. They found that the striated muscles, the ones targeted by physical therapy, account for about 41% of the total closure pressure.
Which is a significant portion, but it is not the majority.
Not at all. Because the vascular plexus, the physical volume of blood engorging that mucosal sponge, is responsible for a massive 31% of the closure pressure.
Almost a third.
Almost a third of the physical force keeping the urethra sealed comes entirely from blood trapped in microscopic vessels lining the inside of the tube.
That's unbelievable. And what about the rest?
The remaining 28% of the closure pressure is derived from the passive tension of the smooth muscle and the connective tissue in the urethral wall.
We really do severely underestimate the passive structural elements of our own anatomy. And the sources back up this 31% finding with external mechanical models, right? Designed by a researcher named Zinner.
Yes, Zinner's models provide the physical proof of concept for the Rudd experiment. They constructed artificial outflow tubes and analyzed fluid dynamics through them.
And the models definitively demonstrated that water resistance is exponentially higher when the outflow tube features a softer, pliable inner lining and a lubricating filler compared to a rigid tube of the exact same diameter.
Right, and translating Zinner's mechanical models back to human anatomy explains a notoriously difficult clinical challenge. What happens when that natural pliability is lost?
Like there are multiple surgeries or scarring from trauma or radiation therapy.
Exactly. The tissue of the urethral wall can become stiff, fibrotic, and unyielding. In urology, this condition is often referred to as a lead pipe urethra, a frozen urethra, or a drain pipe urethra.
The term lead pipe urethra is incredibly visceral. If we go back to the idea of a tube, it's like the difference between trying to pinch a silicone reusable straw closed versus a metal straw.
Oh, that's a perfect analogy.
Right. A silicone straw squishes flat between your fingers, sealing instantly. But if you try to pinch a rigid metal straw, your fingers will fail before you ever compromise the structure of the tube.
Yep.
If the urethral tissue lacks that plush vascular cushion, no amount of striated muscle contraction can force a rigid pipe to seal perfectly.
The muscles simply strain against an unyielding structure, and the zero lumen just cannot be maintained.
Okay, so if maintaining a soft, blood-filled mucosal sponge is an absolute prerequisite for holding back the floodgates, we have to look at what governs the health of that tissue. Why does this vital weather stripping naturally degrade over time, leading so many women to develop stress urinary incontinence later in life?
Well, the structural integrity of the urethra is inextricably linked to the endocrine system. The female urethra is an incredibly hormone-responsive organ. All 4 functional layers, the epithelium, the connective tissue, the vascular tissue, and the muscle, are highly dependent on estrogen.
Estrogen literally dictates the structural volume of the tissue.
It does. The research highlights that estrogen receptors are heavily concentrated on the fibroblasts within the urethra. Fibroblasts are the cellular workhorses that synthesize collagen, which forms the physical scaffolding of the tissue.
And to understand the scale of that, collagen actually occupies twice the volume of muscle in the urethral wall.
Exactly. Furthermore, estrogen receptors are found directly within the endothelial cells of the blood vessels in the submucosal plexus itself.
So a drop in estrogen doesn't just affect muscle tone.
No.
It fundamentally alters the collagen scaffolding and the vascular blood flow.
Yes.
And the sources present some cutting-edge imaging data to visualize this using a technology called sugar imaging.
Right. Sugar stands for super resolution ultrasound. Historically, mapping this vascular plexus relied heavily on cadaver studies.
Which tell you the vessels exist, but not how they behave.
Exactly. Not under dynamic pressure in a living system. Standard ultrasound simply lacks the resolution to see microscopic blood flow in real time.
But sugar imaging allows researchers to visualize this microscopic urethral vasculature in vivo.
It's amazing. By comparing premenopausal women with postmenopausal women, they can finally see the hormonal impact on the vascular sponge.
And what was the contrast in the imaging data?
It was stark. In the postmenopausal cohort, researchers observed significantly decreased blood flow velocity within the plexus. Furthermore, the vascular network demonstrated a much lower fluid capacitance compared to the premenopausal women.
Okay, so if the fluid capacitance drops, it implies the sponge holds less blood and becomes less pliable. But if we follow that logic, it suggests that going through menopause and experiencing an estrogen drop is the sole inevitable trigger for stress urinary incontinence, like the sponge deflates, the seal breaks, and the system fails.
That is a very common assumption, but the biomechanical models suggest a more nuanced reality. It is not an inevitable on-off switch. It is the degradation of a multi-component system.
Okay, walk me through that.
When estrogen levels decline, the vascular cushion indeed becomes thinner and less engorged. When researchers fed the sugar imaging data into dynamic biomechanical models, they found that a depleted vascular cushion loses its capacity to absorb and buffer the rapid shock pressure of a sudden cough or sneeze.
So the weather stripping doesn't just shrink, it loses its shock-absorbing properties.
Exactly. The washer wears out. Losing that vascular shock absorber doesn't automatically dictate that a leak will occur. However, it unmasks any underlying structural or muscular weaknesses that may have been present for years, perhaps from previous childbirth or pelvic trauma.
Because the passive seal is now compromised.
Right, the 41% of closure pressure provided by the striated muscles suddenly has to compensate for the missing 31% from the vascular sponge. The muscles are forced to work much harder to keep the rigid tube closed under shock pressure, and frequently they simply fail under the sudden mechanical load.
Wow. Taking a step back and looking at all these sources, the way we manage intra-abdominal pressure is a masterclass in biological engineering. We started by asking how the body stops a leak during a violent sneeze, and the answer completely upends the idea that it's just about having strong pelvic muscles.
The muscular component is really only one piece of a highly interdependent system.
Right. Continence requires the structural backstop of the endopelvic hammock. It relies on the physics of Pascal's law, where the sneeze itself transmits hydrostatic pressure to actively clamp the upper urethra shut. But fundamentally, none of those physical forces can create a watertight seal without urethral mucosal coaptation.
That estrogen-fed, blood-filled vascular sponge that maintains a zero lumen.
It's incredible.
And viewing the body through this fluid dynamic lens profoundly alters clinical approaches to aging and tissue health. It clarifies why surgical slings, which mechanically pull the anatomy tight, aren't always the definitive solution.
That makes sense.
It provides the physiological rationale for using bulking agents, where materials are injected directly into the urethral wall to artificially recreate that plush cushion. Or why localized hormone therapies are utilized to rejuvenate the collagen and restore vascular capacitance. The goal is often treating the seal, not just the muscle.
It shifts the entire paradigm from mechanical tension to tissue pliability. The physics dictate the treatment.
Absolutely. And as we wrap up our analysis of these sources, there is a broader physiological implication worth considering. We have just explored how a microscopic, localized network of blood vessels acts as a crucial mechanical shock absorber, counteracting massive internal body pressures.
Its primary function in this context is structural, not just metabolic.
Exactly. It is acting as a hydraulic cushion. And it raises a fascinating question regarding human biomechanics. What other hidden microvascular networks throughout the body are quietly acting as mechanical shock absorbers for the physical forces we endure daily?
Just silently buffering the skeleton and organs.
Right. Networks that go entirely unrecognized for their structural role until they begin to fade with age and unmask other mechanical failures.
It really makes you wonder how many other rigid biomechanical problems are actually fluid dynamics problems in disguise. We are so much more fluid than our textbook anatomy suggests.
We really are.
Well, thank you all for joining us on this deep dive. We hope you walk away with a fundamentally new perspective on the complex physics operating inside your own body every single day. Keep questioning the mechanics of how things work, and we will catch you on the next deep dive.